try and put my positive head on and say, look, you know, I've got this far. I was diagnosed in 2012, I'm still here.
I've had a lot of things that have happened through the years. I've had various health challenges, and I've always gotten over them, so it's just like, here's another hurdle.
ACC can be treated. The first treatment, the desired first treatment, is surgery to remove the tumor. And this is in particular important in patients where the tumor overproduces hormones that might be damaging for health, acutely damaging. So the sooner the tumor is removed, the better. We need to differentiate at the beginning to say, is the tumor contained in the adrenal, or is it an advanced stage of cancer? So that means, are there already metastases in other organs, or has the tumor grown into other organs? These are two different situations. Yeah? It is obviously a better outlook the smaller the tumor is, but there can be always treatment be given in both situations.
The single best and probably only prospect of cure of adrenocortical carcinoma is surgery. So you want a surgeon who is experienced, who does lots of these procedures, and who can sort of say to our team meeting with confidence at the end of the operation, I removed all of this and there's nothing left behind.
I was diagnosed almost a year ago now with adrenal cancer. Adrenal cancer is like 1 in a million. It was kind of like, okay, here's my next challenge. Here's the next thing I have to do. I've had a lot of things that have happened through the years. You know, I've had hysterectomies, I've had vertigo, I've had various health challenges, and I've always gotten over them, so it's just like, here's another hurdle. So that's kind of how I felt. I was more worried about everybody else. The surgery was on the 28th of September, which was the day after my birthday. Took out not just my very large tumor, which was 19 centimeters, and the attached kidney, and also my spleen, and then for good measure decided to take a half a dozen lymph nodes for testing, so that all went away.
Surgery is the primary solution, and it is nowadays recommended that the lymph nodes should also be removed together with the tumor, because sometimes some tumor cells could be hidden in the lymph nodes. Patients also ask me often about radiotherapy. In the first instance, in particular in smaller tumors, we would not recommend this, because radiotherapy can also have side effects. Where radiotherapy can have a role is, for example, if we have removed a larger tumor that already started to infiltrate its surrounding. In these cases, there are some publications that suggest that it's beneficial then to have radiotherapy to prevent early recurrence.
So after their initial operation, generally the tumour pathology would come to our team meeting, and the pathologist would report his or her findings. The surgeon may discuss intraoperative findings. We make a decision together, and sometimes in subsequent discussion with the patient as to whether mitotane is appropriate. And then at that point, it all depends on how things pan out.
So what is mitotane? Mitotane is the primary drug we use for the treatment of ACC. And we use them in two situations. Firstly, in adjuvant therapy. Adjuvant therapy means we have removed the tumor in its entirety after surgery, but we want to still give therapy to catch any tiny tumor cells that might have escaped the surgery and that are circulating in the blood. And secondly, we use mitotane in the treatment of advanced ACC, so where the tumor has come back in different locations or in the same location.
It's an oral form of chemotherapy. It's not typical for what we think of when we think about chemotherapy, getting medication intravenously. It's a tablet. Patients have levels measured every month initially, and then once their levels are stable, they would have that blood test done less frequently. We have a particular target therapeutic window for mitotane, so we want to have patient levels in a range that we know will exert the best effect on the tumour, but equally we don't want to overshoot that, because then patients can get side effects from the medication. It has some endocrine or hormonal side effects. So patients who take Mitotain will always take hydrocortisone, which is steroid replacement, because remember, Mitotain knocks out the adrenal cells, and if you have a healthy adrenal gland left behind, its function will be knocked out or suppressed by Mitotain. So they have to take hydrocortisone to prevent them having an adrenal crisis.
I was told that many people being treated with Mitotain. One was a doctor and one was a truck driver, still driving and working. So I thought, well, you know, this is going to be fine. But you know, as time went on, I found out I wasn't tolerating it very well. I spent most of my time asleep. Leslie would get me up in the morning, I'd have a wash and shave, possibly something to eat, take my medication, and the next thing I knew, I was out of it again.
So Mitotain is the only proven adjuvant treatment, so treatment that's given after the initial surgery, that has been shown to reduce recurrence. So one of the frustrating things for patients and for us as clinicians is that if somebody can't tolerate Mitotain, generally there's very little else that we can offer that has a reasonable chance of controlling their disease.
We have a lot of patients that actually tolerate Mitotain very well. In my experience, it's only the minority of patients that really have problems with Mitotain.
We're constantly looking for treatments that will control disease in people who have advanced disease, but also prevent any recurrence in people who we think are cured after an operation. If there's no evidence of recurrence, then the patient will have a scan about every 3 months for the first 2 years after the operation. And then we can push that interval of scanning out to every 6 months for the next 3 years, and that brings us up to about 5 years post-operatively. And then we like to keep an eye on things with an annual scan between the end of year 5 up to the end of year 10.
Right now I'm doing every 3-month scans with the monthly blood check. And then once I get past the 2-year period, then they go to 6-month scans. Yeah, right now everything's feeling fine. My 2 scans that I've had since I've started Mitotain have both been clear. So at this point, I'm inclined to keep going on, hopefully keep having clear scans.
I think you've always got that niggling fear in the back of your head, but I try and put my positive head on and say, look, you know, I've got this far. I was diagnosed in 2012, I'm still here. Yes, it's been a nightmare of a journey for the family as well as me, but I try and just stay positive.